Growing weary of running from room to room, practicing one-tooth insurance-driven dentistry? Then stay tuned for the latest episode of The Lionhearted, where Dr. Stephen Rasner will hand you the blueprint for what many call the gold standard of general practice dentistry.
Hi everyone, welcome back to The Lionhearted with Dr. Steve Rasner. We've spent the last few podcasts talking about the heart and soul of any dental practice. That would be called case acceptance. So just a little recap of the last one. At the last podcast, I talked about discussing with the patient the need for a comprehensive exam without ever saying that. And I talked about a concept that I use called what to do when. So I tell the patient, amongst the many, many things I've studied and learned as a dentist since I started my career, was a concept that I call what to do when. And I explained to them what that means is that how do I know, even me as your dentist, that I'm giving you the best advice? What guides me in that advice? And how do you know as a patient? And I point out the 5 factors that I look at as I'm trying to determine what the best course of action would be for a patient. And mind you now, a patient that comes in that's switching dentists for any reason, that may be an 18-year-old that's completely has an amazing hygiene and no problems along their journey. Naturally, I'm doing these things rather quickly. I might even certainly skip a few things I can skip, obviously if they're not missing teeth, etc. And but generally what I told you on the type of patients that I attract, being that my brand is that I am a place for people to go that's safe, that have past fears and bad experiences. A lot of these people naturally have a lot of past dentistry, a lot of past pathology. So I'm often looking at a myriad of a lot of different things on the radar. So I tell the patient in regards to what to do when is that I'm going to look at 5 factors on them. And the 4 that I covered with you in the last podcast were, number 1, I look at the health of their perio, their bone and their gums, and I'm a big stickler on that. And I tell them I'm a big stickler on that. You know, you have to know, I'm talking to you, my colleagues, that in the course of your career, the thing that's going to make your work hold up the best is not even the most perfect margins on your restorations. Of course, that's important. It's the maintenance of your work. And a lot of us, for some reason, struggle with this and have a hard time convincing ourselves that the patient needs to be part of this. And they do. And a part of a great practice, part of you having a great practice today, 20 years from now, will be how seriously you took this aspect. And I know it's hard to do, because even the most sophisticated, educated patients have a hard time grappling with that they may have to come in 3 or 4 times a year, which many of them do. I have several patients that come in 6 times a year. I'm talking about patients with dry mouth, rapid recurrent decay. I mean, their alternative is extract all their teeth. Why not just come in every 2 months if that's what it takes? So there's no way a lesion can get out of control in that amount of time. I mean, if you talk like this, if you convey the sincerity that I'm bringing right now, I'm pretty sure that your patients will get on board with that. And you got to be really clear, like not let them think for 1 second that insurance is going to cover these extra 2 to 3 to 4 times a year in your office. They really got to be crystal clear on every aspect of the treatment going forward, including maintenance. So the second thing was I look at for caries or the condition of all their existing teeth, not just the tooth they called us with. 3, they're missing teeth. The last podcast we talked significantly about occlusion and occlusal related issues. And then the fifth and last one that I bring up is aesthetics. I'll say to the patient. So the last thing that I want to talk about is what dentists call aesthetics. It's what you call your smile. And so that really means, how do you look to you? How do you look to yourself in the mirror? How do you look in photographs? Are you comfortable with it? Because I always consider that an up to you thing. And that's really how I talk. That's assuming the patient didn't come in for a smile redo, a smile consult. Look, I don't know what it's like in your practice. In the 80s and 90s, yes, there were many more patients seemingly interested in smile makeovers. And again, maybe it's just the culture of the practice you developed. And yeah, I love doing that stuff, and it's so gratifying, just like you do. But you can't make a long-term, in my opinion, booming dental practice around that. And as I talked about in podcast 1 episode, to me, the Triad of Success for any thriving fee-for-service dental practice in the world today would be beginning with the core base of a practice that provides oral sedation. If you're going to provide oral sedation, then you certainly have to know how to take teeth out. If you know how to take teeth out, then you know how to take them out atraumatically, and you bear the responsibility of being able to socket graft or grow bone as needed with the different types of extractions that will come across your operatory. And that's a heavy thing to say. And I don't mind telling you, by the way, if you don't already know this, I give an in-office extraction course, 2 days, and bone grafting 4 times a year in my office. And I have the privilege and the ability for you to practice in my office without a license in New Jersey. You must have an active license in your state or Canada, and you can come in and work on patients. It's pretty amazing course that I'm quite proud of. And yes, so I'm self-serving myself because it's timely in this particular part of the podcast. My email, by the way, which I'm supposed to give out every time, is my name. It's Dr. Rasner, without a period. DrRasner@AOL. And I'll gladly send you any of these things that I allude to during the podcast. So back to the matter at hand, where I talked about aesthetics as the fifth component of the patient. And it's funny because I always include it. I'm pretty sure that my practice is probably consistent with your practice, in that a lot of patients will say, well, if I don't have a lot of other needs and I can afford it, blah, blah, blah. And that's fine with me. That's the way I want it to be. Because treating aesthetics, fixing a worn, not necessarily overly worn dentition from just age, a little incisal wear, discolored old end restorations that might have been maintained with bonding and things like this. That's pretty simple on my radar today of services that I provide. I didn't finish my triad. Sorry. A few minutes ago I was just telling you the triad, and it was oral sedation, atraumatic extractions, and then the third one is, if you're going to go to that trouble, would be surgical and prosthetic implant dentistry. If you have that core, if you are willing to put that core under your belt, which can take you, oral sedation won't take you anything but getting your state requirements together. So there's no learning curve in that. Atraumatic extractions can literally be in a matter of a couple courses with me or somebody else that teaches that subject. You can literally master that and the grafting of bone in a very short time. Implants is a lifetime commitment. You'll never say, oh, I know everything there is to know about implants, because it doesn't happen that way. It's a lifetime commitment, so you'll always take courses. And, that's a discussion for another day. So fixing up somebody's, discolored, worn restorations in their smile zone is quite easy and pleasurable in my office. And so I'll approach that last. And sometimes I'm quite surprised. Like that didn't even come up in the prior discussions of maybe 30, 35 minutes of talking to this patient. And at that point, I turn on a whole new light. Maybe they'll say, oh my God, yes, I've never liked my smile, blah, blah, blah. I hate myself in pictures, things. So it is worthy of not glossing over. You have to certainly bring this up. But it's not my first go-to. I think function and a really healthy oral machine is where I like to begin with regards to my treatment plans. And if they are interested, my go-to would be a big catalog of personal photographs I've acquired of just about any case you can think of over my course of my career. Of course, sometimes this necessitates other kind of treatment for sure, if they're missing teeth, if we're talking about pyrofunction and things like this. But again, the way I approach it, it's my fifth point of the conversation of 5 things I look at, and I say it just like that. I say, listen, the last thing I want to talk about, unless it's been pointed out to me in my prior coaching by Michelle, I'll say the last thing I want to talk about is your aesthetics, how you look to you, how do you feel about that? And so what happens then? At that point, what I do is I actually examine them. And the first thing I say, and this is worthy of you putting up in your brain a little bit, I say, listen, I want you to know before I even start, I'm not one of those dentists that's going to stick you. I don't even use that probe. And I'm telling you this because I think it's a tremendous turnoff, particularly in patients with a bad earlier history. So I'm talking about the Periodontal Probe, or even the pick that we use. Good grief, I can't think right now of the name of an instrument. I tell them, listen, I'm simply going to look with my hands and my mirror and be able to take a look between that and your x-rays and see what I really think is going on here. And look, this is not unique to me. But I have to tell you, I know very, very often what direction I'm going in with this patient. I know where I want to go in about 5 minutes, unless, again, it's a really advanced, complicated case. When I take into consideration what they want after, because you have to ask lots of questions at certain times, which we'll need to go into in these podcasts. And then, of course, what their budget allows, that's what really lengthens the process. Because I just don't get patients to come in that allow me to do whatever I need to do. If they did, I wouldn't be making these podcasts for you. That would be quite easy, wouldn't it? And quite frankly, in all due respect, and I mean that, to all the people I learned from and all the guys that are quite famous in our profession for magnificent work that they've earned that reputation. The last time I checked, there weren't any dentists from Brazil flying into my office for me to do the restorative work. Meaning money is always an issue with my patients. I mean, I can't say always, but almost always. And that's the thing I say when I lecture live. The biggest challenge for the everyday dental warrior like myself and you, it's coming up with a responsible treatment plan for a patient that has less money than they actually need, which is all of them. You get me? I mean, isn't that the hard thing? If they could do whatever I would want them to do, there would be tons of more ortho, tons of more, maybe not tons of more perio. There would be many things, maybe orthodontic extrusion of certain teeth, maybe longer periods of provisionalization, more implants, not less, more bone growing in preparation for the implants. Of course, that would be nirvana for most of us. But you can carve out a beautiful, successful practice, even though you don't have patients that perhaps are in that universe where they can do whatever they want to do. And we can, there's lots of possibilities that you can do in dentistry and compromises that are rather acceptable, in my opinion. So at this point, what I will do is I'll tell the patient, now I'm going to put you back. I promise you I'm not going to hurt you. I'm just going to look at you. Reminding you guys, 70% of the time there's significant others sitting right next to me in the other chair, and that's the way I like it. I will have at this point for sure one of my team members in the room taking notes. And I'll simply go through for the first time, and sometimes things do look a bit different to me as I'm examining them. I'm certainly seeing things I didn't see early on the radiographs. And I will start to formulate a treatment plan based on what they came in for, based on what my eyes see. And at this point, I don't know anything about their budget. Okay, so if it looks to me, and here's where I'm at 38 years into this, and this is just one guy talking to you. Where I'm at is that if I'm looking at a tooth that I really don't think has a significantly great prognosis, meaning it may require a root canal, certainly requires a crown, has a decent ferrule, not an amazing ferrule. What's the rest of their mouth look like? If I'm not really certain, I'm not taking too many chances. I don't want any weak links in this process. You want your patient to be to not need you 6 months after they might have made the very first investment of their lives in their mouth. So it's really important that you, and look, I like to treatment plan and give that treatment plan whenever I can. I've said it already, day one, the first day, if that's possible. If it's not, then don't force it. You can't take it back. So if you're not comfortable, then you have to have a second, and that's okay. You'll have to have a second consultation. I'd certainly hope you don't need more than two, because that would really get to a point, I think, that would kill the treatment plan. And I think it was the last podcast, to me, there are a myriad of situations where you can absolutely treatment plan day one. Okay, that's what's happening. I'm looking through their mouth, and I'm telling someone, I'm not using the word crown, root canal, extraction. I mean, maybe the patient can postulate what I'm thinking about. So I'll say CR, RC, EX. This talk is really quick. I tell the patient before that dialogue begins, I tell the patient that I'm going to be saying a lot of things in the next couple minutes to my dental assistant that may not make any sense to you. Don't worry about it. The second I'm finished, I'm going to hold up a mirror with you. I'm going to sit you up, and I'm going to tell you what I'm thinking about and why I'm thinking about it. Now, I got to stop myself here for you guys. This, what I'm talking about right this second, in my opinion, is the most undiscussed issue of a treatment plan. I have been paid many times by dentists around the United States to coach them and to help their practice rise to levels that they aspire to. And what I'm talking about right now, because it's easy to get your reception room where you wanted to. It's easy to get your front desk and your key people with the proper verbiage. Maybe not easy, but very doable. But this is a thought process that's, if you think about it, that's incredibly complex. I mean, assuming it's not one tooth. It's broken off at the gingival margin and, it's an implant. Multiple factors coming into a treatment plan. It's really a talent to process all this, process as much information quickly from this patient, whatever vibes you're getting from the significant other, and be able to start to intelligently discuss where they're going with this treatment plan. And a lot of times, at the point that I'm going through, I'll stop and I'll tell them that. I'll stop, I'll tip the chair back up, I'll pull my seat out in front of them, and I'll say, before I go too much further, I need to I need more information from you as to where we're going with this. Okay, and that dialogue can go a number of ways. I want you to try to stay with me. I know if you're not home right now, if you're in the car, this can be a little complicated. But when I start to see, wow, this is going to be a lot of factors and a lot of different directions we can go, and I'm going to need their approval, and I need to gauge more out of them what they really want from this, more than the information I have right now. And I think that's probably a very common situation for all of us. Okay, so I'll sit them up, no rush here. I'll back my chair up just where it was when I started. And I may say to the patient, so let me talk to you for a few minutes about where we're going with this. Because where we're going with this has everything to do with what you want from this. So here's my first question. Let's take a patient, for example, that has 6 through 11 or 5 through 12. Some teeth are missing on the bottom. They may have a couple molars. It's obvious they have significant resorption of edentulous areas where teeth have been extracted. And this isn't a 1, 2, 3 thing. And on the top, they have no molars, and they may or may not be wearing a partial. It doesn't matter to me. Okay? So I will say to them, I need to know from you how important it is for you to, where you're at in this process. And I say to them, so I let their guard down. I'll say, look, there's patients that come in here that are younger than you, that if it requires any investment of time or money of significance, they're out. They're done. They actually want me to take the remaining teeth out, and they'll go to a denture. And by the way, to the left of me on the counter is a few boxes of models of every single type of possibility, including a denture especially, on an articulator. Get one made by your local, get a duplicate made sometime in your local lab, because I think it's really important with denture patients or people that are about to go to a denture that they literally hold it in their hand and feel and know what a denture is like. I have consents that indicate all this stuff that you're going to want to email me and ask me for. I just finished them this year. They're brand new. It tells that patient that they've seen the prostheses, if it's a denture. It has the advantages and disadvantages of a denture. Advantages cost, by the way. And they've signed off that they've seen it. That's really important. Okay, so I got to get a gauge on them, and I get all kinds of things. I do get patients that say, well, it depends on what it costs. Then I know I'm giving more than one treatment plan. And I know that the cost differential is going to be significant between those two. And I will allude to that. I will speak to that before I am done and they wait for the financial coordinator. So I'm stopping to get engaged because it helps me. If somebody says, you know what, I've been doing this my whole life, honestly, I'm don't want to put any more money in these teeth. Okay? And then I'll talk about, because in my world, and it depends on how you practice, I'm a pretty anti-partial denture guy unless I support that partial with implant dentistry, right? And so let's say they said to you, look, I know I only have 6 teeth left, but I cannot wear anything removable. Now, I've had patients say that to me as strong of terms as you can imagine, only to find out that the prostheses was north of $25,000, and all of a sudden they got over the gag that they just alluded to. I mean, in a second, they got over the gag. Pretty remarkable technique, by the way. So, I guess I'm saying this to you because not every treatment plan rolls out the same. I had a young patient of mine tell me 18 years ago, I'll never forget it. You know what he said to me? He says he had meth mouth. So he's going to lose all of his teeth. He had drug related caries, and you know what that looks like. But he had all his teeth, and he had all his bone, and he wanted implants. And he just didn't look, I'm sorry for saying this, but I'm a human. He just didn't look like a guy, I read him wrong, that could be possibly fit that in his particular world. And at one point in the conversation, he said to me, there is no fee you can, nobody's ever said this to me before. There is no fee you can give me that'll be too much. And that treatment plan was over $80,000. I don't get many of those. Hardly ever. And this was a early 30-some-year-old guy. It still comes to me, which tells you that you did a good job. And everything held up, by the way. God, thank God. So there's a lot that goes into it. If I think I'm going in that direction just because of where I practice, just because of my history, I may say, I often say this. I said, it's 2018. And you know what the beauty of that is? It's that you can have anything you want, almost to the T. It's just not true that you don't have enough bone, because we can grow your bone. It's just a matter of how much you want what you want, how much you're willing to go through. It may take me a year to grow your bone. And if that, in fact, fits in your financial world. And Michelle's the one that's going to discuss all that with you. So I realize in this discussion we're having right now that there's a myriad of ways this can play out, because it depends on what they need. I couldn't possibly cover every possible treatment in a podcast. I'm just keeping it general so you know my approach, which kind of takes me back to these thoughts have come up in my head as I'm having this with you right now. Other things that can happen. Okay, let me give you scenarios. Things that you can use and say, very powerful, that help you get case acceptance. Let's take the patient that left good old Dr. Joe, and now they're coming to you for the first time. They are in their mid-50s. They have good old Dr. Joe. Let me define him. He's the doctor in town that everybody loves. Everybody likes to go to him. Everybody loves him. You know why? Because you never need anything. And which means you never spend any money. Which resonates to my earlier point that here's the problem in dentistry if you're the dentist. A lot of things that are wrong do not hurt. So you can go to good old Dr. Joe, who's usually a great people person, and he does lots of other things really good besides dentistry. He's just not that into dentistry. And he stays like that for years and years until he retires, sells, or leaves the profession. And now you have this new patient. And here's what you're looking at. Not devastating, but absolutely the need for quadrant scaling root planing, without a doubt. Early pocketing, it's never been treated. Overhangs, overfilled teeth, a couple missing teeth, tremendous, I just said it, but tremendous, numerous overfilled restorations that are failing throughout the dentition. So you got to have a conversation, because your goal would certainly not have been to walk into that. It's much better for you. And this applies to any young docs out there who bought a practice, because that's what also can happen. You might have bought good old Dr. Joe's practice. So let me give you a word of advice if you have done that. You ready? You have to look at this as if you're at a residency, like in a hospital, like a physician in training, and you have to walk on ice, thin ice, for a year or two until people understand and trust you and believe in you and know that you're not going after their pocketbook. Even if you're not going after their pocketbook, which I'm sure you're not, I'm telling you, that will be the perception. So you really have to plant a lot of seeds the first couple years. And the best thing that can happen to you is that you've planted these seeds. I'll talk about that specifically. and then something develops on your watch that you can elaborate. So the conversation might go like this. So listen, I know you went to Dr. Joe for years, and I think he was a really good doctor. No two dentists have the same philosophy of care. And there's a lot of things on you that if I had my druthers, I would start to address. But I don't have to conquer Rome in a day. I'm not going anywhere. As an aside to my audience, I would go after perio #1 all the time. Okay? So if I did see obvious need for that, I wouldn't let that one pass. And if I left them because of that, then so be it. Okay? Because that one that's watchful neglect, you can get sued for that. But you can't, the last thing you want to do is talk about replacing one missing tooth that's been missing for 10 plus years in a new patient you just met. You can say something like, there's lots of teeth on you that the fillings or the restorations have been there quite a long time. And I'm not the kind of doctor that changes things just because they're old. But if they have decay, if I think I can save you from the need of a root canal or a crown, or even losing a tooth, of course, I'm going to recommend that to you. And I got to tell you, I really don't think you got to recognize that people are smart, and people can recognize the truth. And if they don't, if you come off to a patient with great sincerity about trying to segment their treatment and get them to a healthy mouth, if you do that, I think most people get that message loud and clear. So let me take you back to the patient for a second and start to give you what I call wraps. Now a wrap, I don't have much time in this presentation today to give you much more than one, but I'm going to give you one of the best ones. And it's a patient that needs quadrant scaling replaning, that's never had it done. They're in their mid-50s. They have lots of other needs, maybe not a root canal yet, but they have a lot of restorative needs to get them. And this is what I would say. I say, listen to me. I don't know how much you know about this practice, but if you ask around, I'm sure you'll hear this. I've been doing this since 1980. So obviously you can't all say that. But you can say something similar. I've been doing this since 2000. And I met patients that year that were blank and blank, and now so I can say I met patients in 1980 that were 40 that are now approaching 80. And guess what? If they had their teeth in 1980, they have almost all the same teeth, if not all of them, on my watch. And that is because part of my job as a dentist is to inspire you and to educate you. L.D. Pankey said all this. I didn't make this up. And that is true. And so I know what works. That's what I'm saying to the patient. After 38 years, I know what works and I know what doesn't work. And I had patients just like you that I met 3 decades ago that I did the things that I'm going to be recommending to you. And you may need other things as well. I'm going to tell you right now. I'm not going to try to create Rome in a day. I don't have to do that with you. But my goal is to, when you get into your later years, that you don't need all this stuff at that point, because there may be other issues that you are dealing with then, and if your mouth isn't one of them, because you have invested in your oral health from now until that time, and you come in here for pleasant checkups most of the time, and you don't need a lot, I think that message resonates loudly to most patients. And that's a good starting point to convert a patient who's who's been in an insurance-driven practice and never had to spend a lot of money on their mouth. And so you really have to speak earnestly. You really have to, on those patients, try to, and look, if there's one thing you need to practice, if you don't have the skills that these communication skills, then practice them, because they are doable. Right now I'm talking to you on a special piece of equipment that records this. You can use any laptop and record a video and try to It's got to be from your heart, but maybe you don't have, we all don't have the same people communication skills. So why not work on it? Because the payoff of case acceptance is so huge that there should be nothing you won't do. Because the payoff is how you spend your life. Walking in on Monday, Tuesday, Wednesday, Thursday, to accepted treatment plans and feeling good about that case when it's complete because you set it up and you educated a patient to accept this. There's a lot of other facets to this conversation that we'll have down the line, like not, segmenting treatment and trying to let people come up for air. So that's a hard one with those of you that bought a new practice, that somebody bought in finally to your philosophy. So the first time in their lives, last 7 months ago, they accepted whatever it was and they spent a lot of money. Even if that patient comes back and has one of those 7 surface amalgams chipped, I might, and it's hard dentin around it, I might with that patient offer to smooth that out, telling them they absolutely need a crown, but I know they just invested a lot, but I'm not going anywhere, and I think they're okay to their next. I know this sounds radical, guys, but this is how I've built a long-term successful practice that, by the way, had 29 years in a row at one point of consecutive increase of growth and profitability. That's a hard thing to do. You think about that. At 29 years to 2018, that's how many years in a row my practice once went. And I think it's all of these principles. I think it's good work for sure. I think it's being honorable about me being accountable when things didn't work out. And there's so much more to talk about this, about, for example, letting them come up for air, owning it when things don't, treatment planning for the worst scenario. Like you're not sure a tooth needs a root canal because you don't see a periapical lesion, but it sure looks like it's in the nerve to you, but yet they say there's no symptoms. I would treatment plan that as a root canal. Because if a patient buys into you for the first time in their lives, and so many patients do not have this type of care in their mouth, and they finally buy into you, the worst thing you can do is tell them that they need more money to invest 6 weeks into your treatment because you went on the conservative side when you shouldn't. It's 10 times better if you were wrong and you end up telling them, I got great news for you. I thought this one tooth is going to be a root canal. I treatment planned it. You paid me for it. But as far as I can see, we're done treatment. And it's not a root canal. So I can give you a check back. And maybe it'll never pop up again. Can you imagine the difference between that and the earlier scenario, walking into a patient? They always will resent you because they'll think it was your responsibility to tell them from the beginning. Anyway, guys, this is a lot of information. Gosh, I hope it's helping somebody. Thank you so much for your tuning in, and I'll see you at the next Lionhearted.